sơ GMT ultrasound of the shoulder. The GMT, please.
Chairman, ladies and gentlemen, it's my great honor to be here in Vietnam to lecture, so thank you for the invite. My slides have changed colours, so they should be black. I don't know why my slides have changed colour. My screen, the slides are the wrong colour. Ah, okay, perfect, thank you. So, the first lecture today is on ultrasound of the shoulder. And what I'll be talking about in this lecture is the anatomy of the shoulder, various applications that we can use ultrasound of the shoulder for, and for pathology of the shoulder. The ultrasound anatomy is straightforward if you do it in a systematic way. We look at the biceps tendon first, followed by the subscapularis, supraspinatus. We look at the rotator interval and then the infraspinatus tendon. So with the long head of biceps, we scan in the transverse orientation, which gives us an appearance that you can see on the ultrasound image here. And we're looking at the echogenic structure of the long head of biceps. We see that the long head of biceps is kept within the groove by the transverse ligament, with the greater tuberosity on one side and the lesser tuberosity on the other side. And it's important that we can see this structure as an echogenic structure. One of the pitfalls that we know we can encounter is that you can have anisotropy, which means that if you don't have the probe exactly perpendicular to the tendon, it may look low echogenicity, as you can see on the right side. We then look at the long head of biceps in the longitudinal plane, scanning in that direction. And the appearance we should have is of a echogenic fibrillar structure extending down to the muscle-tendon junction. And you can see here on this extended field of view image, the long head of biceps. Often there is a small amount of fluid at the lower end of the biceps tendon sheath. The deltoid muscle overlies the long head of biceps. The next structure we evaluate is the subscapularis tendon, and that attaches to the lesser tuberosity. And we should see this as a nice bead-shaped structure, and we can follow that to the muscular-tendinous junction. The most important of the rotator cuff tendons is the supraspinatus tendon, and this needs to be evaluated from its front border right through to its posterior border. You can see on the coronal images here that the superior border of the supraspinatus has a convex appearance, and I know that I've covered the entire tendon because anteriorly I can see the long head of biceps, which is this structure over here. This is the static view showing the anatomy. This is the region of the subacromial bursa. This is the deltoid muscle, the supraspinatus tendon, which looks like a beak, the greater tuberosity, And this fine black line that you can see here is the articular cartilage of the humeral head. Again, another pitfall to avoid is anisotropy, which is an effect which can be diminished by tilting the probe. So it's important not to overcall this as a deep surface tear. We then look at the supraspinatus in the transverse plane, going in that direction. So anteriorly here we have the long head of biceps, and here is the supraspinatus tendon. And this region here is what we call the anterior interval. Let me just go back. See here the appearance of the supraspinatus tendon. The anterior interval is a very important structure to be aware of. You have the supraspinatus tendon, the subscapularis, on either side of the long head of biceps. And in this region here is the coracohumeral ligament, and deep to it is the superior glenohumeral ligament. And this forms a pulley system around the biceps supporting it. When we look at this in more detail, you can see the anterior border of supraspinatus, the long head of biceps, subscapularis, and those ligaments surrounding this region. The infraspinatus tendon is a continuation really of the supraspinatus. So this diagram artificially separates it. But what we see again is this nice beak-shaped structure. We can follow this down to the muscle over here. And this is a static image of the infraspinatus tendon attaching to the posterior aspect of the greater tuberosity. So what can we use shoulder ultrasound for? Well, there are many conditions that we can see very nicely using ultrasound, and that includes impingement syndrome of the shoulder, rotator cuff tears, pathology of the biceps, frozen shoulder, calcific tendinopathy, and some miscellaneous conditions such as ganglion and ACJ arthropathy. Let's look at impingement first. It's important to realize that this is a clinical diagnosis. So this is a diagnosis where there's painful entrapment of the supraspinatus tendon or the bursa or the biceps tendon between the humeral head and the coracoacromial arch. So this is where the impingement occurs. There's the coracoacromial arch over here. And we can see that there are two regions really where we get impingement, over the region of the greater tuberosity, and that's the arch over there. And so when surgeons do a decompression for this condition, often they will shave the underside of the acromion and divide the coracoacromial ligament. We know that impingement is a cycle of degeneration of the rotator cuff tendon with swelling, and that can lead to impingement of the tendon, and that can, in turn, can lead to full thickness tears. We know that with impingement, that may cause more swelling of the tendon, and so you get this cycle of impingement and pain. And the reason that we are asked to image these patients to perform ultrasound is to see if there is bursitis, to see if there's a significant tear. It allows us to guide injections and also to help with preoperative planning. Let's look at bursal pathology first, which is one of the key features of impingement. The bursa, you can see here, is in the blue surrounding the pink tendon. And you can see that using dynamic examination, that bursa can bunch up against some of the other structures. And we know that when we see that, often the patient will be symptomatic and have a clicking sensation in the shoulder. Looking at the structures more in detail, we can see the greater tuberosity, There's the supraspinatus tendon, there's the thickened bursa, the deltoid muscle overlying, and this region here is the coracoidal ligament, which at surgery can be cut to decrease the symptoms of impingement. Sometimes you have a very thickened and large bursa, and when we see this, often we have to consider that the patient may have a rotator cuff tear, or a condition such as rheumatoid arthritis causing inflammation in the shoulder. When it comes to looking at rotator cuff tears, it's important to realize that the pain that the patient experiences is not related to the size of the tear, but we know that the function of the patient is related to the size of the tear. So the bigger the tear, the poorer the function of that shoulder. We also know that it's important to know the size of a rotator cuff tear because it can influence what kind of surgery is performed. So it may be that surgery can be performed with arthroscopy, but if it's a larger tear, the patient may need open surgery. And we know that in terms of surgery, small tears do much better than large tears. When we think of rotator cuff tears, we think of two main types. One is a partial tear, which is classified according to its location, and the other is a full thickness tear. So partial tears can be graded according to how thick they are in terms of their depth, or in terms of what proportion of the rotator cuff is involved. And they are diagnosed by the presence of a defect, but the contour of the rotator cuff is maintained, so you can see the convexity of this border is maintained. And we know that there is a continuum between a partial tear going on to a full thickness tear. In the other plane, when we're looking from the side of the shoulder, we know that most tears occur at the anterior leading edge of supraspinatus in this position that is shown on this diagram. And this is an example of an anterior leading edge tear, otherwise described as a rim rent tear. We can see as we run the video again that there is some intact fibers over the superior surface of the supraspinatus tendon. And the contour of the tendon is maintained. Another example here of a partial thickness articular side tear. Maintained contour, and there's the defect. And yet another example of a partial thickness tear seen in both planes. And just notice that there is some irregularity of the greater tuberosity. Bony irregularity of the greater tuberosity and the insertion of the rotator cuff is very common and is described as a sign of impingement. It's nothing to be concerned about. There is a specific sign of a partial thickness tear described as the cartilage interface sign. With this sign, you can see the articular cartilage of the humeral head more clearly than you normally would. And that is because there is some fluid between the rotator cuff and the cartilage when there is a tear. And so if you see this sign, if you see the articular cartilage more clearly than you normally would, then you have to suspect that there is a tear. Again, in the other plane. Partial thickness tears mainly occur at the deep surface, but they can occur at the superficial surface of the tendon. And again, the grading is the same. And of course, these may progress to a full thickness tear. And you can see in the other position, that's the kind of typical position of a bursal surface tear. On MRI, often you'll see some associated fluid in the subacromial bursa. And you can see here an equivalent tear on ultrasound with a defect in the superior surface of the tendon and fluid in the subacromial bursa extending in this region. And the final type of partial tear is a laminar tear. This is a tear that extends along the fibers of the tendon rather than across the fibers of the tendon. And typically it occurs in a tendon that is very degenerate. And physiologically, it's as bad as having a full thickness tear. And often there is loss of the superior contour of the tendon, as you can see over here. There's a dip in the superior contour. Here it is in the other plane. We move on now to full thickness tears, which I think are actually more common than partial thickness tears, because usually once the tendon started tearing, it progresses to a full thickness tear. And what we see is an interruption of the tendon with loss of the convex superior border, and the tendon may be absent or retracted, and you may see fluid in the gap. So again, there's various different appearances of these tears, and you can grade them according to their size, being small, medium, large, or massive. And with a massive tear, there is retraction of the tendon. Most tears occur at the anterior portion of the supraspinatus, and they may extend anteriorly across the anterior interval to subscapularis. So here's an example of a full thickness tear showing loss of the contour of the anterior border of supraspinatus. You can see how it's flattened. That's how it should be, where the red line is. And in the other plane, we can see that there's a gap where we would expect to see tendon in this region over here. And there's the other structure which is important to identify, which is the long head of biceps. So this is where I would measure the tear. This is an example now of a full thickness mid-substance tear. So it's away from the anterior edge of supraspinatus. And you can see here, there's the long head of biceps. There is some intact anterior fibers of the supraspinatus, and you can see the position of the tear with the defect. And you should be able to see that in two planes. It's important when you think you can see a tear that you look in the other plane to ensure that you can confirm that in two planes. An important sign that I've already mentioned is the loss of the contour, sometimes described as the sagging bursa sign. So this is what I would expect the contour of the supraspinatus to look like. And you can see here that it's dipped down and flattened where the tear is. And that's where I would measure the tear. Again, another example here with loss of the contour, and there's the extensive tear. And then it may be that if you release the pressure of the probe, you will see fluid filling the gap, and you can see the hypoechoic fluid in the gap representing the tear. Again, notice how irregular the greater tuberosity appears. With massive tears of the supraspinatus and infraspinatus, what you see is an absent tendon because it's been retracted, and you have deltoid fibers lying on top of the greater tuberosity. I'm going to show you the MRI scan of a patient with a similar condition where you can see that you just have deltoid lying on top of the humeral head. There's the retracted tendon. In patients who have a massive rotator cuff tear, it may be that the surgeon may want to try and repair that. It's important, therefore, for us to mention whether there is any fatty atrophy of the muscle belly, because if there is fatty atrophy, it means that the repair will not be successful. So we should assess the muscle belly for the presence of increased echogenicity, and you can compare that to the other side. So you can see here, there's the muscle belly on the affected side, and there's the muscle belly on the good side. And again, just in the other plane. So what's the best modality for cup tears? Well, Depending on where you are in the world, if you are in the USA, they will tend to use MRI or MR arthrography for diagnosing tears. But we know from meta-analysis of many studies that ultrasound and MRI are comparable. The reason that MR arthrography is thought to be better than ultrasound is that if we put contrast into the glenohumeral joint and it escapes into the subacromial bursa, we then definitely know there is a communication between those two areas. And we know that it's definitely going to be a tear. So MR arthrography is considered the gold standard. But I think in someone who's experienced, then ultrasound is a very good way for detecting rotator cuff tears. And what we tend to do is describe the size and the percentage thickness of the tear. As I said, it's important to look for fatty atrophy of the muscle belly if you do see a large tear. And just remember, ultrasound is at least as good as MRI. I'm moving on now to the subscapularis tendon. And we often see subscapularis pathology as part of a massive rotator cuff tear. And often it occurs following an anterior dislocation of the shoulder. And the uppermost fibers of the subscapularis are affected. Often it's useful to compare both sides. You can see the normal subscapularis looking like a beak shape. And on this side over here, the entire tendon is absent, and you just have deltoid lying on top of the humeral head. And again, another example where both sides are compared, normal side and the abdominal side with some fluid seen in the gap. We're moving on now to biceps pathology. And we have several conditions that can affect the biceps. An important one is dislocation of the tendon, but we can also have intrinsic abnormalities of the tendon, which are tendinosis, tenosynovitis, and eventually a tear. These are the normal appearances, and it may be that in normality there's a small amount of fluid in the tendon sheath, as you can see here, and that shouldn't be overcalled as an abnormality. But you may see abnormal amounts of fluid when there is a rotator cuff tear, when there is biceps tendinopathy, or if there is a biceps tear. And you can see here a lot of fluid in the sheath surrounding the biceps. And when you look at the rotator cuff, you can see that there's a tear with loss of the contour of the supraspinatus in this region. Biceps tenosynovitis is an inflammation around the long-head bicep sheath, and these patients can have symptoms of pain or infection of their arm. And when you look on ultrasound, there is swelling, fluid in the sheath, and also increased vascularity, indicating synovial hypertrophy. This is an example of biceps tenosynovitis tendinosis with longitudinal splits within the tendon. And you can see that there's increased vascularity indicating a repair process. This is a classic sign of a biceps tendon rupture. We call this the Popeye sign. The patients will often present with a pop sensation, and then they'll have bruising and swelling. And the reason we call it Popeye sign is because it's meant to look like Popeye, but actually, if you look carefully at Popeye's biceps, they're actually very small. It's his forearms that are big, so maybe it's not the correct way to describe this. And what we notice when the biceps is ruptured is that the groove is absent. So in this position here, we expect to see an echogenic ovoid structure, and there is nothing there. And we know that if you injure the ligaments that hold the biceps in place in the anterior interval, so you can see here in this schematic, the long head of biceps in green, there's the groove where it normally sits. It's surrounded by these supporting ligaments, as well as the subscapularis tendon. And if you have injuries of any of those structures, the biceps can fall out of the groove and become subluxed. And in the initial phase, it will look like this. And eventually, you can have a tear and dislocation of that tendon, and that tendon can even fall into the middle of the joint. And you can have an appearance like this, where the tendon lies deep to the subscapularis tendon. And I'm going to move on now to talk about calcific tendinopathy. And this is calcification, hydroxyapatite calcification that occurs within the rotator cuff tendons, and it can be a very painful condition. And how it appears, or when it appears, will differ according to what phase of the calcification there is. In the chronic phase of disease, the calcification is very firm and hard and rock-like. But in the subacute phase, when the calcium is precipitating, then the calcification can be quite soft-like and quite liquid-like. And that can sometimes leak into the space around the tendons and cause a lot of pain. And when there is the resorption of calcium, often that's when patients will present. And clinicians will often mistake this condition as being an infection of the shoulder joint because the patients are in so much pain and have a red shoulder. And we know what the X-ray findings are like. We can see the calcification. And on ultrasound, calcification is normally very easy to detect. You can see this echogenic structure. You can see there's associated subacromial fasciitis over here. And you can see posterior acoustic shadowing from the region of calcification. On MRI, it can be a very difficult diagnosis to make because tendons are normally black on all sequences on MRI. You may notice an area of increased low signal within the tendon indicating calcification. Another example here of an acute phase calcification on X-ray. You can see this rather faint-looking calcification, and that corresponds to this area of calcification within the supraspinatus tendon. And notice in this phase of calcification, often there isn't as much acoustic shadowing as in the chronic phase of calcification. This is in the other plane. And then we're now moving on to a pathology actually arising from the shoulder joint itself. In some patients, they can present with infraspinatus atrophy or painful rotator cuff muscles. And that's because there is compression of the subscapular nerve as it exits the shoulder in this region here, which is the suprascapular notch or the spinoglenoid notch, it's also described as. And if you have anything that is occupying this region, such as a ganglion or a tumor, it can compress the nerve and result in atrophy of the muscle. So we can see here, this is how we would scan the patient. There's the spinoglenoid notch posteriorly. There it is on MRI. I don't know where my ultrasound has gone, it's disappeared. We will often see a cyst in the spinoglenoid notch, and it's possible to see that on ultrasound. And I do have a case of that. The final topic is the ACJ. This is a joint that is often injured, but X-ray is a very nice way to look at the ACJ because we can assess the alignment well. But on ultrasound, what we might see is a widening of the gap as we scan through the ACJ. You can see here the gap should be no more than 7 millimeters, the same as on X-ray. In elderly patients, sometimes they will present with a lump overlying the ACJ, which is what we describe as the Giza phenomenon. And when we see this, we need to think of a large rotator cuff tear with pressure from the shoulder joint going through the ACJ, giving a cyst or a ganglion in this region over here. So to summarize, I've taken you through the anatomy and technique for scanning the shoulder, and we've spoken about impingement and cuff tears, specifically partial tears and full thickness tears. We've also looked at the biceps tendon and conditions when you can see dislocation of the biceps. And then finally we've spoken about calcific tendinitis of the rotator cuff and some problems that you can encounter with the acromioclavicular joint. Thank you for your attention.
Thank you very much, Professor Siêu.